to the cloud.
Prepare to and prepare to learn a lot about a very timely issue. I will have a few announcements at the end. We will have time for question and answer, and say that I will have a few announcements at the end, and then Judy will finish up with a wrap up. Okay, Kip, go ahead.
Thank you very much, Ann. I do have some slides. I'm going to turn to them here in just a minute. Let me just recap the first two webinars. In part one of this series, we reviewed the history of the debate about why U.S. costs are so high. We saw that the debate began in earnest in early 1970 when Senator Ted Kennedy introduced a single payer bill, and a Minnesota doctor named Paul Elwood persuaded Nixon to support a newfangled form of health insurance that he called the Health Maintenance Organization. Elwood said HMOs would reduce the rampant overuse of healthcare that he claimed was the cause of healthcare inflation. He said the alleged overuse of healthcare was caused by the fee-for-service method of paying doctors. HMOs, he said, would reduce overuse by reversing the fee-for-service incentive with a method of payment called capitation, which means payment per patient per year. We also saw in part one that if you endorse capitation, you must also endorse limited choice of provider, and that HMOs also micromanage doctors with utilization review and other methods. These tools, capitation, limited choice, utilization review, pioneered by HMOs, came to be called managed care by about 1985. In parts one and two, we saw that Elwood had no evidence to support his diagnosis, overuse, nor his solution, HMOs and managed care. We saw that high prices, not excessive quantity of medical services, explain why U.S. costs are so high compared with other countries. For 50 years, however, managed care proponents have focused on excessive quantity, quote unquote, when they should have focused on excessive price. Managed care backfired so badly that by the late 1990s, HMOs were subject to a torrent of bad publicity and hundreds of bills in Congress and state legislatures to protect patients against HMO abuse. This reaction was dubbed the HMO Backlash. Finally, in part two, we saw the invention of managed care 2.0 after the backlash, or as its proponents like to call it, value-based payment. The leading example of value-based payment today is the Accountable Care Organization. Tonight, I want to review the impact of the managed care diagnosis and solution on Minnesota. Minnesota, along with California, led the nation down the managed care path. We were among the first states to enact a law enabling the formation of HMOs. We were among the first 6 states to privatize Medicaid. Minnesota, along with Washington, was the first to propose universal coverage relying on HMOs and preferred provider organizations to contain costs. We were along the Twin Cities, along with the Bay Area in California, led the nation in being captured by HMOs. And finally, Minnesota today leads the nation in with the most Medicare beneficiaries enrolled in Medicare Advantage. Not surprisingly, because Minnesota led the nation in promoting HMOs, Minnesota suffered the toxic effects of managed care before other states did. We began the 1990s, Minnesota began the 1990s as an average cost state, but wound up being a very expensive state by 2000. And Minnesota still is. And Minnesota's healthcare industry has undergone tremendous consolidation thanks to the spread of managed care. Now, let me see if I can make well, I've got a toolbar getting in my way here. I'm having a hard time. Here we go. I'm going to concentrate tonight on the privatization of Minnesota's Medicaid program and the creeping privatization of Medicare. Both problems illustrate the power and the irrationality of managed care groupthink, and both have contributed to rising healthcare costs. Now, I want to start by showing you a graph that, let me talk about two definitional issues. Privatization is in the dictionary. It means shifting the provision of service from a government agency to private sector entrepreneurs. I don't know if deprivatization is in the dictionary, but you're going to hear me say it. It means kicking the HMOs and PPOs out of Medicaid and Medicare. We talked about CMS the last two webinars. It stands for the Centers for Medicare and Medicaid Services, the agency that runs Medicare and Medicaid. It replaced HCFA, the Healthcare Financing Administration, in 2003. Now, I want to show you the graph. I think I showed this in the first webinar. This is a graph showing you that Minnesota was an average cost state. This graph shows you Minnesota's per capita healthcare spending as a percent of the national average. And you see we were 1 or 2% above the national average until the early 1990s. And then our per capita costs soared in a very short period of time, and then leveled off to 10%, which is where we are today. Now, the fact that Minnesota is a high cost state is not well known. And the primary reason for that is that the Minnesota Department of Health has been claiming just the opposite since it began issuing annual reports on Minnesota spending in 1993. Here you see data for the last several years of the 1990s. You see, for example, that the Department of Health is claiming that Minnesota's per capita healthcare costs in 2000 was substantially below the national average of $4,000 and $450. They were saying essentially that our costs were 10% below the national average. And if you go back and look at this data, you see that our costs are 10% above the national average. This graph, the data you see in this graph, is produced by the Office of the Actuary within CMS. CMS is the national keeper of national healthcare expenditure data. You don't need to know the differences in the methodology between the Minnesota Department of Health and CMS reports. All you need to know is that the methodology is different. It always has been different. And it's just not appropriate to compare two numbers, one of which was calculated one way and another was calculated another. To add insult to injury, the Department of Health, when they issue their reports, here's an excerpt from their 2003 report. When they issue their report, they don't bother to tell the reader that CMS has a very different perspective on Minnesota's healthcare costs. So here you see a paragraph taken verbatim from the department's 2003 report saying Minnesota spends less per capita than the nation. See table 2. Here you see the national number is much higher than the Minnesota number. And there's no indication that CMS says the problem, that the relationship is just the reverse. Minnesota is much more expensive than the national average. What I will tell you is the Minnesota Business Partnership agrees with me. This is an excerpt from a report by the partnership in 2015. The Minnesota Business Partnership consists of more than 100 large Minnesota businesses, 3M, United Healthcare, Toro, Land O'Lakes. And this report was, the lead author was Karen Brainerd, the CEO of Health Partners. And you can see here that the report says Minnesota spends more per capita than the national average, ranking 36th in a 2009 study conducted by CMS. They must have been well aware of the Minnesota Department of Health's data. They don't mention it anywhere in their report. Here is more information from the Business Partnership Report. They say Minnesota hospital costs are very high compared to the national average. If you measure hospital cost on a per capita basis or on a per discharge basis. And over here you see a rather astonishing number. This number over this chart over here on the right side says that the 100 most common outpatient procedures cost 39% more in Minnesota than the national average. The partnership says Minnesotans do not use more medical services than the average resident of other states. They say our use of emergency room visits is relatively low. We use roughly the same amount of hospital care as people in other states. That should remind you of our last webinar, where we found that Americans don't use more medical care than people in other countries that spend half what we do. The problem, obviously, then is our prices. And here's some evidence, more evidence indicating that Minnesota's high costs are due to high prices, not overconsumption of healthcare. This is an excerpt from an article in the Minneapolis Star Tribune saying that a recent study looking at 240 services found that Minnesota ranked 5th highest in the country in prices for those services. So the question we have to ask about Minnesota is the same question that we were asking in the last two webinars about US costs vis-a-vis other countries. That is, what's driving Minnesota prices so high? Well, the answer is the same. High administrative costs driven by the spread of managed care and the rapid consolidation of the entire Minnesota healthcare system, also driven by the spread of managed care. The evidence of rising administrative costs at the state level is not good in any state. The research, I should say, but we can infer from the solid evidence at the national level, which shows that as managed care spread, administrative costs went up. The evidence on the consolidation of Minnesota's system is indisputable. Here's one of the few studies I'm aware of where anybody in Minnesota sought to track what was happening to administrative costs as enrollment in HMOs in Minnesota rose in the 80s. This is a report from the Commissioners of Health and Commerce, published in 1993, showing that on a per member basis, HMO expenditures on healthcare rose 354%, but the spending on administrative costs soared by 502%. Now, typically, you would expect in most sectors of the economy that as the sales of whatever it is we're talking about go up, that the administrative costs would stay the same or drop because the same administrative staff is being spread out over a rising sales volume. That's not what happened here. What we see here is the HMOs are becoming less efficient as they get bigger. Back to the Minnesota Business Partnership report, they say that Minnesota's system is characterized by a high degree of integration. It's another word for consolidation, and in all sectors, insurance and hospital and clinic. Now, I'm going to devote a few slides here to describing what happened in Minnesota, particularly the Twin Cities, during the 80s. And the reason I'm going to spend a little time on that is it set the stage for an enormous merger explosion in the Twin Cities in the early 90s. And that in turn is what explains that rapid increase in our costs that we saw on the graph a minute ago. The rapid growth of HMOs in the Twin Cities attracted the attention of analysts all over the country in the 80s and 90s. And some people actually traveled to the cities to see what was going on. The Office of Technology Assessment is one of the agencies that sent people to the Twin Cities. You can see that they aren't sure why HMOs were formed and prospered in the Twin Cities. I would say if they looked a little deeper, they would have found that Paul Elwood, the guy that coined the phrase HMO, was running around, he's from Minnesota, was running around the Twin Cities talking to Fortune 500 companies like General Mills, urging them to support HMOs and to explore actually contracting with one. But in any event, the important number we see here is that from 1971 to 1978, HMO enrollment grew at an annual clip of 27%, reaching half the population by the end of the decade. This is one of the acts that I won't dwell on this for long. I just want you to know that Minnesota was one of the first states to pass legislation making HMOs legal. Here are some excerpts from that law. You can see the legislature thought that they were addressing mounting costs of healthcare, and that their intention is to eliminate the barriers to the promotion of health maintenance organizations. And this last item here is the funniest line in the bill. It is further the intention of the legislature to closely monitor the impact of health maintenance organizations on the costs, accessibility, and quality of healthcare. That never happened. And when I get into the discussion of the history of the privatization of Medicaid, you will see what I mean. Here is a report on the penetration of HMOs in metropolitan markets that appeared in 1991. You can see that the authors are saying that HMOs have achieved almost minority status in a few markets, notably the San Francisco Bay Area and Minneapolis, St. Paul. Here is some data from that report. You see here in this left graph that the Bay Area had 46% of their residents were enrolled in HMOs, compared to 44% for the Twin Cities. There were some other metro areas coming up behind the Twin Cities, but they were substantially behind. I'm having a hard time seeing my. Here are two more reports about the consolidation of the insurance market in the Twin Cities. Both of them saying that by 1990, it was becoming very difficult for newcomers to crack the market because it was so highly consolidated. Here is evidence indicating that the hospital market in the Twin Cities was highly consolidated by 1990. You see here that the top three hospital clinic chains, HealthSpan, Fairview, Healtheast, along with North Memorial and Robbinsdale, together controlled 73% of the hospital market. Now, pop quiz. If you were here for the webinar in October, why was the Twin Cities hospital sector so concentrated by 1990? Answer, the HMOs had gotten so big, and because they controlled large populations, they could tell them where to go or not to go, they were extracting enormous discounts from the hospitals, compared almost 38%, compared with almost no discounts that the other traditional insurance companies were getting. That's the 3.2% figure. And that in turn caused the hospitals to think, boy, we can't keep giving away discounts like this. We're going to have to merge in order to develop power commensurate with the power of these new HMOs. So as the 1990s dawned, you would think that the Minnesota legislature and two commissions that were appointed to conduct business in the early 90s would have been worried about the growing consolidation of the hospital insurance markets. Perhaps it could be excused for not seeing how administrative costs were soaring, but they should have seen how rapidly the Twin Cities market was becoming consolidated. They did nothing about that. In fact, they threw gasoline on the fire. The legislature appointed a commission in 1989. They issued its report in January 1991. And you can see here that the commission stated that Minnesota should control healthcare costs through managed care organizations such as HMOs and PPOs. Why? Because these insurance companies will lower costs for the state. There was not a shred of evidence offered for that statement. I attended every one of those commission meetings. I know that no evidence was introduced at any of them. The legislature took the report, passed a law saying, yep, we're going to contain costs using HMOs. We're going to set up another commission to come back and tell us how to do that. And the Minnesota Healthcare Commission then came back in May of 1993 with another report saying, we want to encourage competition between HMOs. They didn't call them HMOs, they called them integrated service networks. Habit managed care advocates have gotten into all around the country promoting HMOs, but calling them some other name. They said that these ISNs will compete with each other. They called that managed competition. And you'll note here at the bottom, they said ISNs are similar to health maintenance organizations. The legislature then took this recommendation, passed legislation in the spring of 1993. Here's a quote in the Minneapolis Star Tribune from Representative Lee Greenfield, the leader of the HMO advocates in the Minnesota House at the time. And you can see he says, now we made a very strong commitment to use managed competition as a technique for doing that. Kablam! This chart shows you what happened thanks to those commission reports starting in 1991 and the legislature's favorable reactions to them in 92 and 93. Everybody saw the handwriting on the wall. Everybody understood that now HMO growth was going to accelerate. Everybody needed to be something in a hospital clinic chain that was big. The HMOs were saying to themselves, boy, if the hospitals are going to merge, we better start merging. And so what you see here is a graph showing the largest of the mergers. I won't ask you to look at all the labels here. I just want you to look at the darkened labels. You see that at the center of these spider webs were insurance companies. Allina Health System had just become an HMO. It no longer is. It's a hospital chain. Health Partners had just been formed by the merger of Group Health and Med Centers in 1992. And Blue Cross, seeing the HMOs getting big and locking up doctors and hospitals, they began to sign contracts with hospitals and clinics all around the state. Here is some indication of how badly consolidation worsened in the insurance industry. You see that the four largest insurance companies, Blue Cross, Allina, Health Partners, and Preferred One, increased their market share from 64% to 80% of the Minnesota health insurance market in 2 years. Now, to drive home how jaw-dropping this merger explosion was, I'm just going to quote an op-ed in the St. Paul Pioneer Press by Brian Dowd. He's a conservative economist at the University of Minnesota. He published an op-ed about 6 months after Lee Greenfield was quoted saying, now we're going to try and manage competition, with the title being State Legislation to be Poison for Healthcare Competition. And he said, preceding and concurrent with the discussion surrounding ISN legislation is an unprecedented level of consolidation in the health plan and healthcare services market in the Twin Cities. If we have time, I've got it here with me. I might read some other pieces of it. Essentially, he said this does not bode well for healthcare costs in Minnesota. This is an excerpt from one of many studies I could have shown you tonight, saying that consolidation anywhere, hospitals in this case, generally drives up prices if there are no price controls. So back to this graph, you see that the merger explosion occurred right there at the bend in the curve, right there at 1992. There is no other explanation for this rapid increase other than the impact that this merger explosion had on consolidation and the spread of managed care, the rapid adoption of managed care tactics by insurance companies that hadn't previously done that, which in turn drove up administrative costs for doctors and hospitals. Today, 8 hospital clinic chains dominate Minnesota. You can see here they dominate by region. This reminds me of feudalism in Europe in the Dark Ages. Only instead of warlords running fiefdoms, we have overpaid executives running hospital clinic chains. These 8 chains plus Health Partners, Blue Cross, and Medica together run the Minnesota healthcare system. It's a very different system from the one we had in the late 80s. These are, again, just the worst of the decisions made by Minnesota policymakers prior to the 1990s. I could run up another slide for bad decisions made after the 1990s. But what I'm doing is explaining how Minnesota became a high-cost state. And all of these acts, the 83 legislation authorizing the privatization of Medicaid that we'll talk about, the 2 reports from the commission, the legislation passed by the legislature in 92, 93, and 94, and the 96 legislation privatizing Medicaid in Minnesota carried statewide, all of them were done without any evidence supporting managed care. And I'm just going to ask you to look briefly here at the authors and the dates of some of these excerpts. In the top of the slide, you see the U.S. General Accounting Office, 1993, saying little empirical evidence exists on the cost savings of managed care. And note, this is 1993. This is more than 2 decades after Paul Ellwood convinced Ted Kennedy and Nixon to support HMOs because they would bring costs down. The lower half, you see an excerpt from the Congressional Budget Office, 1994, stating that it's difficult to assess whether managed care is saving any money. Here's a report from the Kaiser Family Foundation on the impact that HMOs have had on Medicaid. There's little evidence, however, to suggest that managed care either increases or decreases physician visits, preventive services, or hospital care. By 2006, there was still no evidence that managed care worked. This is a quote from Robert Galvin. He was the chief medical director at General Electric for 15 years. He has a lot of experience trying to figure out what it takes to reduce healthcare costs for employers. And he said in 2006, we still do not know conclusively to what extent traditional managed care actually saves money for employers. So there was no reason for the Minnesota policymakers to make the decisions they did. Minnesota has paid a steep price for that. Now, I want to turn to the privatization of Medicaid because it illustrates the power and irrationality of managed care groupthink. It began in 1981 with a letter from Paul Ellwood to the Al Quie administration and ended in 1996 when the legislature passed legislation authorizing privatization in all 87 counties in Minnesota. In late 1981, Ellwood learned that the Reagan administration was going to invite states to participate in a demonstration to see if HMOs could cut Medicaid costs. On November 13, 1981, Ellwood sent a 21-page proposal to the Department of Public Welfare. That's the predecessor to what is now the Department of Human Services, the agency that runs Medicaid. In that letter, Ellwood urged the Quie administration to let Minnesota participate in the demo and to apply to the Reagan administration. Ellwood proposed that DPW, the Department of Public Welfare, select 3 counties, 1 urban, 1 suburban, and 1 rural, in which Medicaid recipients would be forced to enroll with an HMO. Does that sound familiar? We talked briefly about this direct contracting entities scheme that the Trump administration cooked up just before they left office. Ellwood proposed that the DPW compare Medicaid spending in these 3 counties with Medicaid spending in adjacent counties that would remain unprivatized. And he proposed that the demonstration run over a 3-year period. Now, that sounds like a rigorous test of the HMO concept, right? Good. Let's let the test go forward. Nope, that's not really what happened. Ellwood proposed that the taxpayer subsidize the HMOs, that is, pour more money into their coffers on a per beneficiary basis than would be poured into the control counties. Ellwood proposed 3 types of subsidies. First, he proposed an exclusion for Medicaid recipients who, quote, failed a health screen. your guess is as good as mine what that means. He didn't explain. I think it means you do something to guarantee the HMOs get healthier patients, enrollees. Secondly, he proposed that DPW would pay all hospital costs in excess of $5,000 per admission. Third, he proposed that DPW would pay for all out-of-network care. Incredibly, unbelievably, DPW bought Elwood's proposal, and on April 30, 1982, they submitted an application to the Reagan administration, HCFA, proposing a nearly identical version of Elwood's proposal. Quote, "The Twin Cities HMOs have been extremely effective at reducing the use of expensive health services," said DPW. Not a shred of evidence, no footnotes. You see, that's the modus operandi of Medicare advocates. You say stuff and people are supposed to believe it because you said it. Then, having bragged about the HMOs, DPW turned right around in their application and proposed to subsidize the HMOs as Elwood had proposed, but by a different method. Here at page 17 is what they proposed. There is a possibility that benefit levels may need to be reduced in the HMO counties because existing per capita payments to the HMOs may prove insufficient to cover the full scope of Medicaid services. DPW proposed to experiment with HMOs in Hennepin, Dakota, and Itasca counties. Amazingly, HCFA approved DPW's application to conduct a 3-year experiment over the calendar years 1986, 1987, and 1988. In 1983, the Minnesota legislature enacted a law authorizing DHS basically to privatize Medicaid in any county that they got permission to do it, for which they got permission from HCFA. And the law specifically authorized then DHS to suspend freedom of choice. All the poor people in Medicaid, you're just going into an HMO whether you like it or not. Predictably, the HMOs could not or would not give DHS the data they needed to carry out the comparison that Elwood had promoted, to compare the HMO counties with the adjacent control counties. And in the summer of 1987, barely 18 months into the demo, DHS asked HCFA for a 2-year extension of the demonstration period. HCFA refused in September of 1987. Why should they go along with this? That should have been the end of the demonstration. That should have been the end of the privatization of Medicaid in Minnesota. It wasn't. Congress intervened and extended the demonstration through 1996 with 3 laws passed in 89, 90, and 91. I have no information on how that was done. I think it's reasonable to say that what happened is the HMOs went to some members of the Minnesota congressional delegation and said, guys, we're having some trouble here with HCFA, they're being picky. We'd like you to step in. In 1997, Congress eliminated entirely the requirement that the states get permission to privatize Medicaid, and Minnesota was home free. This was all done with no publicity, even though Minnesota and the HMOs were violating the 1985 agreement with HCFA. The demonstration, quote unquote, was not only extended to 1996, DHS was allowed to privatize Medicaid way beyond the 3 demonstration counties to the whole state. And in 1996, the legislature said you get to do that to Minnesota Care as well. It gets worse. In 1993, a member of the DHS staff, Stephen Folds, I think I'm pronouncing his name correctly, Foldes, attempted to complete the study that DHS had promised HCFA it would do. What he tried to do was compare Medicaid spending in Hennepin and Dakota counties, 2 of the 3 demo counties, with Medicaid spending in 5 other unprivatized metropolitan counties. He discovered that DHS still didn't have useful data from the HMOs, at that time Group Health, Medica, Metropolitan Health Plan, and UCare. DHS had no data at all on mental health services. But Folds was able to make 2 valid comparisons on Pap smears and mammograms and found that the HMOs were performing terribly. He wrote up his report and called for better data. The HMOs got wind of the report and rushed to DHS to demand that they suppress the report. And in a minute, I'm going to show you the headline from the Star Tribune. I want to stop now and just tell you why it is impossible for an insurance company to save Medicaid or Medicare any money. We start with the proposition, with the statistics you see here at the top, that the typical insurance company overhead is 20%. That is, you give an insurance company $1 worth of premiums, they keep 20 cents to run their shop, and they give the other 80 cents to doctors and hospitals. Now that 20% number drops to 15% once an HMO begins to act as a DHS middleman, once they have a contract to insure Medicaid or Medicare enrollees. What that means is that the HMOs must cut the cost of medical care by 15% just to break even. Now, so how are they going to do that? Can they cut provider payments by 15%? No, it's extremely unlikely because Medicaid already pays very low rates. Medicaid typically pays rates 60% of Medicare rates, and Medicare rates are typically 80% of private sector rates. So the only option the HMOs have is to reduce utilization. That after all is their claim to fame. It isn't clear exactly how much they reduce utilization. 5% is probably a good number, and that means that leaves the HMOs 10% in the red. Conclusion: HMOs can break even and make a profit only if they're overpaid by at least 10%. Now, let me just show you several slides that confirm these numbers I was just using in the previous slide. This is a quote from the Wall Street Journal in 2006, quoting an expert on Medicaid. She says that when states run their own Medicaid programs, by which she means when they run the program without inserting HMOs between the taxpayer and the doctors and hospitals, they spend an average of 4 to 6% on administrative costs, and the rest, 94 to 96%, goes to doctors and hospitals. But for Medicaid HMOs, only 80 to 85% of the dollar goes to doctors and hospitals. And that's because, according to this expert, the HMOs have overhead costs of 15 to 20%. More confirmation of the 15% figure. Here's a quote from the Lewin Group, currently a subsidiary of United Healthcare. They report that managed care organizations must typically achieve a 15% savings simply to break even. More confirmation. This is a quote from an article in Health Affairs by Bruce Vladeck, who administered Medicare under the Clinton administration, and his co-author Barbara Cooper. Note the entertaining subtitle, Theory Meets Reality and Reality Wins. He's explaining the same thing I'm explaining to you now, the impossibility of an insurance company saving money for a public program. Here he says that the HMOs have to incur medical expenditures 10 to 20% less than what the fee-for-service program for Medicaid or Medicare was paying. This is a report that backs up what I'm telling you. California, again, a leader in promoting managed care, by 2000 had privatized their Medicaid program in half the state's counties. And this report from the highly respected National Bureau of Economic Research, rather conservative outfit, found that the privatization of Medicaid in California led to a substantial increase in government spending. Now, the problem is even worse than what I've just reported to you. Not only does privatization mean that the taxpayer now has to pay for HMO overhead, which we didn't have to pay for before, we now have to pay for a doubling of the Medicaid agency's overhead. Here's the first statistic to know. Before Minnesota's Department of Human Services privatized Medicaid, DHS's overhead was 4 to 5%. That's a little higher than Medicare's overhead of 2%. Why? Because they have to means test the program. Here's the only study I'm aware of that found that after a state privatizes its Medicaid program, the administrative costs for the administering agency double. You see here that they report that Arizona's Medicaid agency had overhead costs of 11.6%. And they compared that to administrative costs for unprivatized, what they call traditional Medicaid programs in adjacent states, which they say ranged from 4 to 5%, which is what we just saw for DHS. There are reasons why DHS's workload goes up. Here's a report from two experts on Medicaid reporting that Medicaid managed care programs have proven enormously taxing for Medicaid agencies. Here's a report from Michael Sperrer, a national expert on Medicaid, making the same statement. Medicaid managed care actually increases the state's regulatory role. So if privatization drives up DHS's administrative costs from 5 to 10%, and if DHS has to pay the HMOs 10% more just to get them to play ball, that means privatization has raised Medicare costs by 15%. And the increase in administrative costs doesn't stop there. Not only does the taxpayer pay more now for HMO administrative costs, and more because DHS has to spend more to regulate the HMOs, privatization drives up provider costs, doctor and hospital costs. Here are two reports to that effect. One saying that everybody reported increased costs for managed care, and the increased administrative costs were especially difficult for smaller clinics in rural areas. The bottom slide, you see a statement that managed care imposes significant new administrative costs on addiction clinics. I'll stop here just for a second to read portions of this to you. This is an excerpt from the Minneapolis Star-Tribune in 2001 reporting on Attorney General Mike Hatch's investigation of Blue Cross Blue Shield. You can see that he found that Blue Cross was intentionally giving parents and doctors the runaround in order to save money by denying and delaying coverage. They found that Blue Cross would immediately reject any claim that was missing any information, even if they already had the information on hand, like a social security number. And you see that Blue Cross routinely put doctors on hold for 10 to 15 minutes. So that's an enormous amount of overhead to add to a system for the privatization of Medicaid. No wonder the HMOs refuse to cooperate. It's no wonder that we don't have any good data on how much HMOs have cost us. Here's the study that was the newspaper article in the Star-Tribune that was published in 1994 when someone leaked the Folds study to the Star-Tribune. You can see there the headline, study shelved after HMOs complained. Study that raised concerns about how well HMOs serve the poor fell on deaf ears at the Human Services Department. Here's an excerpt. They found that the HMOs are providing far fewer cancer detection tests than women who can insured in the private sector. Far fewer mammograms, far fewer pap smears. One last chapter to this sad story. In the summer of 2004, I and several people who were working with a predecessor to HCAM called the Minnesota Universal Healthcare Coalition, met with Matt Intenza, representative who at the time was the minority leader in the House, and we asked him to write DHS to find out if DHS still had no knowledge of whether privatization of Medicaid had saved money. And DHS Commissioner Kevin Goodnow replied on December 16, 2004, "We do not have a methodology that could accurately assess whether managed care has cost us more or less than fee-for-service." So there's that sad, crazy, corrupt story for you. Minnesota basically broke its promise to HCFA in 1982 to perform a rigorous study comparing 3 privatized counties with 3 adjacent control counties. Sounded great, never happened. Now I want to take the next 15 minutes to talk about the privatization of Medicare, also an example of the power of the managed care groupthink, the fervent belief that overuse is the problem. and that the only way to address it is with the managed care tools. Take a look at the upper right-hand corner. This is data showing you the overhead costs for insurance companies that participate in Medicare Advantage. I'm going to refer to Medicare Advantage throughout, but that name was not actually adopted for the privatized portion of Medicare until 2003. You see here that the overhead is about 14%, which is about close to the 15% number I was using for Medicaid. We saw in part one that Elwood persuaded Nixon and the Democrats to insert HMOs into Medicare in 1972. Today, that program is called Medicare Advantage. It's huge. It enrolls a little over 40% of all Medicare beneficiaries now. All types of insurance companies, not just HMOs, have been allowed into Medicare Advantage since 1998. Proponents of inserting insurance companies into Medicare faced the same dilemma proponents of privatizing Medicaid faced. If insurance overhead is 15%, how do the insurance companies make a profit? Answer, only if they're overpaid. How did that happen? That's what we're going to explore here in the remainder of this webinar. Unlike the privatization of Medicaid, Medicare beneficiaries were never forced into HMOs. They always had a choice. They could remain in traditional fee-for-service Medicare, or they could enroll with an HMO, or after 1998, any type of insurance company. The fact that so many beneficiaries remain in fee-for-service Medicare means we don't have to infer that Medicare Advantage plans are overpaid. We can measure the overpayments fairly accurately. We can compare how much CMS spends per beneficiary in the fee-for-service program with how much CMS spends per beneficiary in the Medicare Advantage program. The overpayments have been as high as 30% over the decades. They are probably 15 to 20% today. Between 1972, when Congress first allowed HMOs into Medicare, and 2004, there was only one reason why HMOs were overpaid. They enrolled healthier people, but CMS paid the HMOs as if they enrolled beneficiaries in average health. Since 2004, the overpayments have had two causes, the one I just mentioned, and upcoding. Upcoding means adding diagnoses to claim forms that are inappropriate or inaccurate or flat out don't exist, but they make your patients look sicker, and CMS pays the HMOs more for allegedly sicker patients. Now, I want to start by reviewing the evidence that the HMOs have always enrolled healthier people. Again, we won't look at the entire excerpts here. I just want you to notice the titles, the authors, and the dates. Here we have a report from the U.S. General Accounting Office entitled "Growing Enrollment Adds Urgency to Fixing HMO Payment Problem." They note that Medicare has paid HMOs more than it would have paid for the same patient's care provided by fee-for-service providers. Here we have another report from the U.S. General Accounting Office, 1999, stating that numerous studies conducted by us and others have demonstrated that the Medicare program spent more on beneficiaries enrolled in health plans than they would have spent on them if they'd stayed in the fee-for-service program. USGAO 2000, it's largely excess payments to HMOs, not managed care efficiencies, that enable plans to attract beneficiaries by offering extra services. And look at this last line. Nearly all of the 210 plans we studied received payments that exceeded fee-for-service costs. Here again is our friend Bruce Vladeck, the administrator under the Clinton administration, and Barbara Cooper, stating that favorable risk was always the way HMOs made money. Medicare has lost money for every beneficiary enrolled in managed care because they were healthier. And he was saying he thinks the overpayment is on the order of 10 to 12%. I think that's just a little low. Now, Congress never instructed CMS to overpay the HMOs and later the Medicare Advantage plans, simply because the idea of inserting HMOs into Medicare was poorly thought out. There was no evidence for it. And they just didn't anticipate what was going to happen. What happened was, once HMOs got into Medicare, they enrolled healthier people. CMS did make a feeble effort to reduce the overpayments, but they used a risk adjuster. That's the name we use to describe the algorithm used to adjust premium payments to insurance companies to reflect the health status of their enrollees. CMS used a really feeble demographic risk adjuster to adjust the premium payments that only used 4 factors: age, sex, Medicaid status, and institutional status, meaning whether you're in or outside of a nursing home. To show you how bad this demographic risk adjuster is, it predicted only 1% of the variation in spending. Now, why am I using the word predict? Well, remember, in fee-for-service, you don't have to predict anything. You pay the bill after the service has been rendered. You know what happened. You know how sick the patient was. But when you're paying insurance companies, you're paying ahead of time. You're paying before the year in which coverage will take effect. And so CMS has to predict, has to guess for each HMO that's in Medicare Advantage, how healthy or sick is their average enrollee. So let's just take an example here of what it means to predict only 1% of the variation. Assume that the average cost of a Medicare enrollee is at $10,000 per year. Assume a health partners enrolls beneficiaries averaging $9,000 a year. So the overpayment obviously is $1,000. In an ideal, efficient, humane system, you'd want to get that premium down to $9,000. But CMS only subtracts 1% of that overpayment, or $10, and health partners takes $990 for no other reason than they enrolled healthier people. Here's another way of looking at how bad a 1% risk adjuster is. You see here in the leftmost column, a column representing the healthiest 20% of Medicare beneficiaries. And what you see here is that old 1% risk adjuster overpaid for that healthiest quintile of Medicare beneficiaries by 2 2/3. Now, cast your eye way over to the right side, and there you see that they're underpaying vastly for the sickest 1%. They owe $1 and they're paying 17 cents. That's how bad a 1% risk adjuster is. So Congress started pushing CMS to come up with a more accurate risk adjuster. And CMS said, and I think most people who were thinking about the problem agreed, that the solution is to add, not just rely on age, sex, Medicaid status, and nursing home status, but to start using diagnostic codes. There's a code for diabetes and a code for cancer. There are several codes for these more complex diseases. And you can see in this table that it makes sense. Any Medicare beneficiary with a diabetes diagnosis is on average 1.5 times more expensive than the average Medicare enrollee. And you see similar risk scores for cancer and congestive heart failure. So CMS spent 4 or 5 years developing a diagnostic-based risk adjuster, and they implemented it in 2004. Unfortunately, the new risk adjuster, although it was a tremendous improvement over the demographic risk adjuster, could only predict or explain 12% of the variation in spending. And I won't walk you through this same example, but you know now what happens. Now CMS only subtracts 12% of the overpayment, and health partners walks away with $880, certainly much better than $990, but it's an awful lot of money. And you can see the immense incentive that a crude risk adjuster like this gives to insurance companies to seduce the healthy to leave fee-for-service Medicare, join a Medicare Advantage plan, and when they get sick, to get rid of them. Here again is that same chart we looked at moments ago. On the left column, you see the healthiest 20%. And now the 12% risk adjuster is paying 1.62, overpaying by 62%. But there's underpaying. They're still grossly underpaying for the sickest 1%, but the discrepancy isn't as bad. But the accuracy here is awful, and the incentive remains powerful for insurance companies to cherry pick and lemon drop. Now, you would think that when CMS implemented the diagnostic risk adjuster in 2004, you might think that because they're clawing back some of the overpayment, that maybe HMO enrollment, Medicare Advantage enrollment would slow down. The reverse happened. You see here a rapid increase in enrollment after 2004, the year that CMS switched over to the diagnostic-based risk adjuster. I've never seen a study explaining this, but the only explanation I can think of is that by switching to a diagnostic risk adjuster, CMS, despite its good intentions, gave the insurance industry another way to cheat. And boy, did they cheat. And now they are upcoding like mad. You couldn't upcode before 2004 because who cared? CMS was adjusting on age, sex, Medicaid status, and nursing home status. Now that they're using some 3,000 diagnostic codes, it pays and pays big time to upcode. To give you some idea of how serious this is, let me report to you on these next two slides show you excerpts from an article published in Modern Healthcare on October 28, just where are we? A little over 2 weeks ago. The US Department of Justice is accusing Kaiser Permanente, the poster child for the HMO movement in America, of upcoding. You see here that they're accusing them of coercing employees to upcode, resulting in an error rate of about 75%. They say that more than half of Kaiser physicians said they were forced to add diagnoses they didn't consider to be appropriate. Kaiser held coding parties where physicians would sit around and look up new diagnoses to add to their patient visit records to make them look sicker. And the DOJ is alleging that every added diagnosis is worth about $3,000. So you see the problem here that that Congress really set a trap for themselves back in 1972 when they allowed HMOs into Medicare. From 1972 to 2004, HMOs were vastly overpaid because CMS's demographic risk adjuster only predicted 1% of the variation. But when Congress tried to solve the problem, instructed CMS to solve the problem, CMS improved the accuracy of the risk adjuster to a miserable 12%, but that made the overpayments worse because now the insurance companies could upcode, something they couldn't do before 2004. There's just no way to stop this other than to terminate the Medicare Advantage program. I hope that this discussion of the Medicaid privatization and Medicare privatization has illustrated for you the power and the irrationality of managed care groupthink. This fervent belief that US and Minnesota costs are high because doctors order services that patients don't need, and they do that because they cave into the fee-for-service incentive and make more money. And the solution is HMOs or direct contracting entities and other HMO wannabes. Managed care groupthink led to the privatization of Medicaid and Medicare, and that in turn has raised costs for the entire system. And I hope it's clear from all three of these webinars, the September, October, and now November webinars, that the problem is basically managed care itself. They made the wrong diagnosis. The advocates of managed care did. They thought overuse was the problem when they had no evidence. Price was the problem, and price was driven up by administrative costs and consolidation. And both of those problems were worsened by managed care. Managed care is the disease that was worse than the cure. And I'll stop there.
Thanks, Kip. So we have some questions. First, HCMC is one of the few institutions that never merged. Why do you think that is?
My guess is because they are the largest provider of coverage to the uninsured in the state. It's probably the main reason other parties were not interested in approaching them. And my guess is that, that the people who would work for a public hospital also have a different set of moral standards. They're just less inclined to want to succumb to the commercialism that managed care inflicted on the rest of the country. And I would say HCMC was big to begin with. They weren't like some of the smaller hospitals, some of which got wiped out by the spread of managed care. But good question. But HCMC they started their own HMO. They felt threatened by the spread of managed care, Metropolitan Health Plan. Their doctors started that. And HCMC is developing contractual relationships with some clinics, and I believe North Memorial and Robbinsdale, for the same reason that other hospitals have, in order to maintain referrals and probably to maintain some bargaining power with the insurance companies. Good question, though.
Thanks. Our next question is, with Medicare Advantage, how can these plans get rid of sick patients when they begin to cost the insurance companies too much?
They do it primarily by frustrating them. What we have are numerous studies showing that sicker patients disenroll from Medicare Advantage plans at a higher rate than patients in good health. And it is reasonable to draw, and that when they get back to fee-for-service Medicare, then they have the hip replaced, they have some other expensive service. And the disproportionate number of disenrollees from Medicare Advantage plans who are sick, and their tendency to get expensive procedures within a few months after they get back into fee-for-service Medicare, is enough evidence to infer that what's going on is, as we saw in the slide about Blue Cross, is they're frustrating patients either by delaying care or denying care. But there's an ocean of anecdotal evidence. I'm sure if you were to go out on the internet and just look for stories by people who regret ever signing up with a Medicare Advantage plan, you'll find them by the hundreds or the thousands. I've heard many myself.
Say, Kip, may I make a comment right here? And I'll just say something I think I've learned recently. Medicare did provide for so-called, Medigap plans early on. I think within 1 year after the Medicare law was signed, people could buy some kind of supplemental insurance. They didn't have to go through any underwriting process if they signed up right away at age 65. What happens when people now they get kind of lured into signing up for Medicare Advantage plans? Joe Namath's retirement plan seems to be getting on TV and selling Medicare Advantage to everybody. And then they find out that it's not working well for them. They leave their Medicare Advantage plan. They try to go back and sign up for a Medigap plan and find out that they have to go through an underwriting process, and it's not very easy to qualify for that supplemental insurance. So that is really a bind for Medicare enrollees.
Yeah, I'll offer just a quick anecdote about a relative. He underwent triple bypass surgery at a hospital in St. Paul, and Aetna tried to. He signed up with the Medicare Advantage plan. I urged him not to, and Aetna tried to kick him out 3 days after the surgery. His social worker had to go to bat for him. Now get this, but they delivered a whole lot of frozen food to him, I think like 6 weeks later when he got home. So like they're big on the little freebies and hard on you when you need healthcare.
Great, thank you both. Next question. Are insurance companies smarter than Congress?
I would say they are motivated far more than members of Congress are to understand the intricacies of risk adjustment. Risk adjustment makes eyes glaze over. And yet members of Congress have got to understand it someday, or we will see Medicare entirely privatized either by Medicare Advantage or by these direct contracting entities that the Trump administration proposed. And it will happen because the insurance companies will be able to, they understand the game. They understand how to cherry pick and lemon drop. And then if you start using diagnostic codes to improve the risk adjuster, they know how to upcode. That is complex stuff. I mean, doctors don't go to medical school to learn that. I must say it's not my favorite part of the health policy wars, but we all have to understand it. The problem is busy legislators are probably bored by it. It takes time to understand it. And the insurance companies, they make out like bandits if they understand it. So I guess what I would say is the insurance companies are far more motivated to understand how to game the system than members of Congress are.
Great. Next question. Medicare Gold plans were abolished in 2018 in Minnesota, which pushed Advantage plans. Is it true if Advantage plans cannot return? Is it true if those in Advantage plans cannot return to regular Medicare because they can use pre-existing conditions?
That's almost perfectly stated. And Ann, I think Ann was just talking about that. You have a 6-month window after you become eligible for Medicare to decide whether to buy supplemental coverage. And I think the rationale for that was Congress didn't want people waiting until they were sick to buy supplemental coverage. They wanted you to make a decision within 6 months after you join Medicare. But a lot of people, when they turn 65 and join Medicare right away and go right into a Medicare Advantage plan, because they've had Joe Namath yakking at them for 10 years about how wonderful it is, they're never told that they missed that 6-month window. And then if Humana or Health Partners or Kaiser frustrates them and they go back to traditional Medicare, now the supplemental insurers are free to ask them about their health history and to charge premiums accordingly. In the first 6 months after you are eligible to enroll, they can't. And I hope I stated that correctly. If you disagree, jump in.
I mean, I believe that's correct. I haven't, I'm going to study that a little bit more because that was kind of news to me.
Okay.
It's the underwriting process that becomes a barrier then.
That's right. And so the problem, it's not as if you're legally locked out of a supplemental policy. They're free to, if you have cancer when you bail out of the Medicare Advantage plan, the price they may quote you will be so prohibitive you can't afford it.
Right.
Next question. Operationally, how do Advantage plans manage to enroll healthier patients and drop sicker patients?
There are two parties at work here. One is the beneficiaries themselves, and the other is the insurance companies. All human beings tend to have most rational human beings do not want to be in an HMO. They do not want to be an insurance company that limits the doctors and hospitals they can see and will attempt to interfere in the doctor-patient relationship. But people are willing to go into Medicare Advantage plans, or people under 65 are willing to enroll in PPOs or HMOs. In the case of people under 65 for lower premiums or possibly lower deductibles. And people over 65 are willing to give up their freedom to see any doctor they want in exchange for the extra services that Medicare Advantage plans can offer because they're overpaid. They can afford to offer eyeglasses and hearing aids and dental services and umpteen thousand frozen meals to my relative because they're overpaid. Sicker people tend not to want to make that bargain. So beneficiaries, on the one hand, contribute to this, what's called favorable selection into Medicare Advantage plans. Medicare Advantage plans contribute to it both by cherry picking, which is advertising in a certain way that brings healthier people into their ranks, setting prices for certain drugs if they provide Part D coverage, that will scare away the sicker people who need certain drugs. Holding informational meetings on the second floor where people in wheelchairs can't get up. It is not legal for Medicare Advantage plans to flat out ask you, Mr. Sullivan, tell me your health history and I'm going to decide whether to let you in or not. They can't do that, but they cherry pick by means that are legal. They lemon drop, they get rid of sicker people by the means I discussed 5 minutes ago. They frustrate and deny care to patients who need more expensive care. And in some cases, particularly mental health, they can make you wait for months for services because they just don't contract with enough therapists. I think I've covered the major methods they use to cherry pick and lemon drop.
Next question. What is the attention span of the average voter? How do we get the message out in brief messages that will appeal to the voter?
Well, I know I can't ask you to clarify. I must assume the question is about the overpayment to Medicare Advantage plans. We have a similar problem with this direct contracting entities demonstration that the Trump administration proposed. The message is difficult, and I've had conversations with some an expert at PNHP in their national office about how we're going to do this. She agrees this is a very difficult topic to explain to people. I'm working with Ed Weisbart to shop around an op-ed about this. So far, we have struck out at the New York Times and one other big newspaper. They don't tell us why they don't want to read the op-ed. I thought it was fairly easy to understand. My guess is that this topic is boring, and so far, editors have heard almost nothing about it. And so when Ed and I come in with an op-ed saying you got to get this out here and help people understand we're about to lose Medicare to Medicare Advantage, and we've got these DCEs that are about to take over, it's just outside of their knowledge at the moment. So my short answer is we do have to figure out how to do this. And it may be that we're never going to communicate accurately about risk adjustment to the average person on the street. It may be that we'll have to content ourselves to educating Bernie Sanders and Pramila Jayapal and legislators in both parties here in Minnesota when we seek to kick the HMOs out of Medicaid. That I think is doable. I mean, I hope you agree that I made this topic somewhat accessible tonight. If I didn't, please let us know.
Next question. Where does the Affordable Care Act fit in?
I wish I'd have had time in these 3 webinars to bring us up to date on the role that the Affordable Care Act has played in promoting managed care theology. Obama, Senator Baucus, the other authors, Liz Fowler, the other authors of the Affordable Care Act, they bought managed care 2.0 hook, line, and sinker. They were totally focused on reducing utilization and thought almost not for a minute about excessive administrative costs and consolidation and the role they were playing in driving prices up. The Affordable Care Act is what gave us the Accountable Care Organization. And the Accountable Care Organization is adding to administrative costs and not saving any money. some of the programs that the Affordable Care Act promoted, for example, a so-called value-based payment program that punishes hospitals for having 30-day readmission rates in excess of the national average. Now, if ever there was a program that needs accurate risk adjustment, that's it. Because you just know that hospitals that serve poorer people, dealing with more stress when they get out of the hospital, are bound to have higher readmission rates than hospitals in better off neighborhoods. And yet the Democrats, as you know, that bill was passed without a single Republican vote. Democrats stuck that awful program into the Affordable Care Act thinking, oh, wonderful, this will induce the hospitals to reduce readmissions, take better care of their patients, and costs will go down. That has not happened. It looks like all they did was, the hospitals have done is game the system. They are using more observation stays, meaning they admit you, but they keep you on the premises, but you're not officially admitted, so that when they let you go, you don't drive up their 30-day readmission rates in case you're really sick. And worse, there are a couple of studies that indicate that the hospital readmissions program has increased the death rates for people with, I think it's congestive heart failure and pneumonia. So the short answer is, where does the ACA fit in here? We have to give them credit. That act greatly reduced the uninsured rate, but what it made available were insurance policies with very high deductibles. Deductibles so high people often can't afford to use their insurance, and it worsened the problems, leading to higher costs, higher administrative costs, more consolidation, and of course, more money funneled into the coffers of the insurance industry.
Okay, next question.
Thank you, Carol. I like that idea.
My Down syndrome daughter, now 49 years old, lives in a group home. Years ago, the operator hosted a sales pitch by Hennepin County to move her to an HMO. As her guardian, I opted not to choose an HMO. My assumption is she is not in one. Is it possible that we were able to escape the sweep?
Is it possible to escape what?
Escape the sweep.
I still didn't understand the last word.
Sweep. Escape the sweep.
Can you spell it?
SWEEP.
I don't know. I don't understand the question.
Okay.
I think that would.
If the question is how do we get the HMOs out of Medicaid? I was at a meeting. I hope maybe Diane Peterson is with us tonight, that Diane hosted, where someone proposed enacting a law, finding legislators to author a bill that would give Medicaid beneficiaries a choice between a fee-for-service payment method and one of the HMOs. It'd be interesting to see who would object to that and why.
Next question. What, if any, danger is there that the insurance plans that offer traditional supplements will quit offering those plans?
I haven't heard any news suggesting that they are feeling so stressed that they may leave the market. I haven't seen any indication that here in Minnesota, the regulators make it tough for them to raise their premiums when they think they have to. I guess my answer is I have no reason to think that they're in any kind of financial trouble. I think that's why they're regulated. That's why states regulate them. I think we'd begin to hear news if from the Commerce Department if any of them were in trouble.
Okay, next question. There are 4 states that do not allow underwriting for the supplemental plans after switching out of Medicare Advantage plans. All other states are allowing underwriting. Is that correct?
My understanding is those 4 states, and they don't include Minnesota, outlaw underwriting. They make it possible for you to get out of a Medicare Advantage plan. And oh yes, I understand the question now. That yes, the way that was phrased is correct. So if you are in a Medicare Advantage plan and 2 years go by after you're eligible for Medicare, and for whatever reason you're frustrated by the Medicare Advantage plan and you leave and go back to traditional Medicare, in those 4 states, I think New York is one, the insurance companies cannot, quote unquote, underwrite. Crazy term, I don't know where it came from. It basically means charge you more based upon your prior health history. They can't do it in those 4 states.
Okay, Kip, we have 5 more questions still. If you return to Medicare after leaving Medicare Advantage, you are still covered by traditional Medicare. You are not obligated to purchase Medigap policy, just the Part D prescription private plan. If you choose to purchase a private Medigap policy, you will be screened for pre-existing conditions. Is this true?
That's all correct. Yeah, you're still covered by traditional Medicare, but I think as we all know, traditional Medicare has had some big holes in it for a long time.
Next question. How do you feel about pharmaceutical drug price controls proposed for Medicare patients?
Oh, we should have done that a long time ago. There's simply no reason why the entire country shouldn't enjoy some limits on drug prices. And because the disabled and seniors are the biggest consumers of the most expensive drugs, that seems to me a no-brainer. We can get into this. We all know what the drug companies are going to say. Oh, innovation, new inventions will all dry up. That's nonsense, because all the important research that leads to the really innovative drugs, the vast majority of the research that leads to innovative drugs is financed by the taxpayer. So the taxpayer shouldn't be paying an arm and a leg for these newer drugs that we paid for.
On Facebook, the insurance companies have been sending out their ads for Advantage plans. So I've spent much time on there trying to educate the average consumer. Is there one article that I could post to these consumers to explain why they should not use Advantage plans?
I saw someone ask this question on the One Payer States listserv. I will look for it. And Judy, I don't know how you want to handle this, or Ann, if I could find it, I could send it to whoever is asking this question. I think it's a very good question. We really ought to find one good article to send to people.
Yeah, we can figure out how to send that, I'm sure.
Okay.
Ann, did you want to add something?
No, well, we are going to be posting some information. Stuff comes in almost every day. I think if you saw the article from today, but I want to ask Val's question because it's kind of fun. If we cook a bunch of Minnesota hot dishes, do you think we could get all of the legislators together to watch Kip's 3 webinars? I know, who's going to organize that?
I'm up for it.
So
I was going to save that one for the end, but okay.
Oh, I'm sorry.
It's okay. It's okay.
We're okay. We might have to wrap up the questions pretty soon. I do have a few announcements to make.
Yes, yes. There are 2 more questions, basically. CMMI, the source of DCEs, is tasked with decreasing costs without lowering quality. Who is supposed to police that?
Congress is supposed to police that, but the Congress is like the Minnesota legislature. They pass these ideas that have not been thought through, and then hand it off to an agency. In Minnesota, it gets handed off either to DHS or the Department of Health, and in Congress gets handed off to CMS. What's worse about CMMI, the Center for Medicare and Medicaid Innovation, is they were given $1 billion a year for a decade to just sit there and cook up these ideas like the hospital readmissions program, accountable care organizations, et cetera. They do have, reports are made on how well their funny little ideas work. And something like 50 of 54 ideas that they threw against the wall failed in the first decade. So we have reports that Congress can't plead ignorance. But they just, I forget when, it was recently, gave the CMMI another $10 billion for the next decade to keep sitting in their treehouse and coming up with new ideas that aren't going to work.
Okay, next question. Who are the Medicare supplemental insurers? Do insurers who offer Medicare Advantage policies complicate matters by also selling Medicare supplement insurance?
I didn't understand that question. Can you read it again?
Sure. Who are the Medicare supplement insurers? Do insurers who offer Medicare Advantage policies complicate matters by also selling Medicare supplement insurance?
Good question. I don't know the answer. I'm sure there's some overlap.
And the last kind of sort of question is really more of a statement. Kip, why don't you write the article regarding in regards to why not to choose Medicare Advantage plans?
I'd love to. I have a lot of that stuff in my head. But I've got a couple other projects ahead of me. I'm sure there's somebody else out there that's written something very good. Thank you very much for asking. If we don't find something really good, by God, I'll get right on it.
Great. Thanks. Now we're going to turn over to Anne for some announcements.
Oh, thank you so much, Kip. That was amazing.
Thank
And,
you.
And we will invite Kip back, believe me. This is information we do want to get to the legislators. So our Legislative Relations Committee is working really hard with Kip on putting this information together, and we will be working to find ways to make sure that we can meet with them. And good news is that, and you'll hear about it in our December 4th quarterly meeting, there is, for the first time that I know of ever, plans to start a single payer caucus in the state legislature, which is very promising. Anyway, a few announcements. Thank you for hanging in there with us for this whole very complicated but very important information. We would like you to help us get information out also via our social media platforms. We're active on Facebook, Twitter, YouTube, and Instagram. We have a wonderful social media kind of expert, interested person, Carolyn Hankey, who you will also meet on December 4th. We've been working hard on getting interesting and timely posts up on these social media platforms. What we need is a lot more interaction with these sites. We need people to be pushing it out there, read, post, comment, etc. We'll talk more about that on the 4th. Judy is working on getting our calendar on the website up to date so that you will be able to check for events under Get Involved on our website. We have an interesting opportunity for a rare now in-person event to outreach and, of course, build membership and support. We are going to be tabling at the Minnesota Farmers Union Convention in Minneapolis on November 20th and 21st. We do have several volunteers, but if anyone is interested in this in-person opportunity to be an advocate, you could write your name, contact information, email address, and phone number in the chat, and we'll save the chat and I will get in touch with you. What we would be asking for is all day Saturday and Sunday, just a 4-hour shift, Saturday morning, Saturday afternoon, Sunday, just offering it as an opportunity since we've had so little opportunity to do in-person events. Our next quarterly meeting coming up is December 4th, Saturday, 9:30 a.m. and obviously via video conference. Please share invitations for our educational events and our meetings. They are free and open to the public. I think I said we're thinking of a follow-up to this series with Kip to deal more in depth with managed care, high deductible, high premium plans, since we didn't talk a whole lot about that during this series. But again, complicated and so much information. So stay tuned for that sometime in the next year. On December 4th, Rose is going to be talking about, Rose Roach, Executive Director of MNA, Minnesota Nurses Association, and a member of our Healthcare for All Minnesota board, is going to present information on the newest threat to original Medicare, which are these direct contracting entities that you've heard mentioned this evening. This is a serious problem and a change in the way CMS is proposing to deal with Medicare enrollees who are not in Advantage plans. We need advocates to be aware of this threat and take action, and we're going to be helping show you ways to take some action. We need members of Congress to be aware of this. It was very under the radar and just popped up last summer. Advocates are appalled and have been trying to get the word out and register their concern, but we need more voices. So help us get members of Congress aware. On Tuesday, January 13th, Physicians for a National Health Program Minnesota is holding their annual meeting and program. I should not have said tentatively because they do have plans for a program. And it's we'll get more information out about that at the quarterly meeting. One thing they're going to talk about is so-called information on so-called public options insurance plans and a couple other really good topics. And then fundraising this month. We have set up to be aligned with Give to the Max, which is kind of traditionally for year-end giving. So you can watch for that as an opportunity, or go to our newsletter. I want to pitch our newsletter where we've put out 2 editions of a monthly newsletter, October 1st and November 1st. And we've got a really good dedicated committee working on that. Ken Engelhardt, Mark Brockie, Judy Barton, and me. And you can go to that newsletter and use the donate button, or go right to the website also. We have matching funds from a generous HCAM supporter. So many thanks for joining us this evening. Oh, one more thing. You'll all get these slides so you don't have to memorize this. We are still encouraging that people talk to members of Congress about expanding Medicare. Not looking very promising right now because of all the things that have been sort of chopped from the human infrastructure bill that is still yet to be negotiated, and we hope passed, but lots of cuts, and we need to make our voices heard on that as well. Then we would like you to help us. Physicians for National Health Program, the national organization, has put a petition on their website to inform people about the threat to traditional Medicare. Medicare Advantage is already draining the Medicare Trust Fund, but this new threat, DCEs, it could end Medicare as we know it. Very serious. So there's a petition on the website for you to sign. And then I will, one last thing, point of personal preference. Today is Veterans Day, a day set aside to honor those who served and continue to serve in our armed forces. I also want to say that there are many ways to serve, and I think about this, about the people who are working to protect our planet, who join the Peace Corps, or Teach for America, or volunteer to help the hungry and the homeless, and so many other causes. For those of us working toward a healthcare system that serves everybody, one way we can honor veterans is to help strengthen and preserve the VA health system. And of course, before it was Veterans Day, it was Armistice Day, signed the armistice ending the war to end all wars, signed at the 11th hour on the 11th day of the 11th month. Just a little history lesson in case you haven't heard enough about that today. Anyway, thank you very much. My contact information, and I'll turn this over to Judy for final thoughts and a wrap up.
Great, thanks, Anne. I just wanted to thank everyone for joining us and remind you all that you will receive an email with the presentation materials and a link to the video in a few days. You will automatically be redirected to a survey after you leave the presentation, and we would appreciate you filling out the survey so that we will know how we did and if there's anything else that you would like us to cover in these educational events. You can go ahead and leave by using the red leave button to exit Zoom. Thank you again, everyone.